Hello everyone in Cardio Minds channel, and after we discussed in the last video the acute management of ventricular arrhythmias, today we are discussing the long-term management. The lines of treatment that we are discussing today are the pharmacotherapy, device therapy, and the catheter ablation. Let's start with the pharmacotherapy. First of all, we should emphasize that the optimal treatment of the underlying cardiac disease, especially the heart failure, is mandatory to reduce the mortality due to heart failure and sudden cardiac death. That's why it is class 1 to have an optimal medical treatment including ACE or ARB or ARNI, plus MRA, beta blockers, and SGLT2 inhibitors in all heart failure patients with reduced ejection fractions before thinking of the specific treatment of ventricular arrhythmias. The antiarrhythmic medications have an important role in the management of ventricular arrhythmias in symptomatic patients. However, no antiarrhythmic so far except for beta blockers has shown a reduction in all-cause mortality. Moreover, the antiarrhythmic drugs sometimes may have the potential to cause adverse events, like for example QT interval prolongation provoking torsade de pointe, negative chronotropic effect leading to significant bradyarrhythmias, deteriorating heart failure, and increasing the risk of ventricular arrhythmias in patients with Brugada syndrome. This table was published in the guidelines this year, showing the whole antiarrhythmic drugs that we use in the acute and chronic treatment of ventricular arrhythmias, including their effects on ECG, indications, dose, side effects, contraindication, and precautions. So we need to read it carefully in order to be oriented about each antiarrhythmic drug before we prescribe it. What we need to do before we prescribe a sodium channel blocking medication to a patient like flecainide or propafenone. First of all, you need to assess the patient risk profile before initiation, including history of any known heart disease, ECG abnormalities, or abnormal echo. If there are any contraindications like Brugada syndrome, prior MI, severe LV dysfunction, severe valvular heart disease, severe bradycardia, bundle branch block, second or third degree AV block, so we need to avoid this medication. If there are any precautions like any degree of LV dysfunction, LVH, valvular heart disease, first degree AV block, or prolonged QT interval, so in this case we need to assess the risk-benefit ratio to decide whether we are going to start this treatment or not. If there are no precautions, so we can initiate the treatment safely. But in both situations, you need to follow up the ECG after 1 to 2 weeks in order to check if there is any change in the complex duration or in the QT interval, and after any increase in the dosage. If there is increase in the complex duration more than 25% or abnormal exercise test like new bundle branch block or widening of the QRS with exercise more than 25% or the QRS more than 130 milliseconds, as sometimes the effect of antiarrhythmics may not appear except with exercise, in this case we need to consider to change to a different drug or reduce the dose, or sometimes measure the drug serum level. If there are no any abnormal features in the ECG, so continue the treatment, inform the patient about warning symptoms, periodic ECG should be done to follow up the complex duration, control the dose if there is any change in renal or hepatic function, and be aware of any potential drug interactions. If we are going to prescribe a medication that is QT prolonging, so we need also to assess the patient risk profile. If there is long QT syndrome or baseline corrected QT interval more than 500, so do not initiate this medication. But if there is hypokalemia or hypomagnesemia, renal or liver failure, LV hypertrophy, heart failure, or the patient is taking another QT prolonging drug, even if non-cardiac drug, in this case, you are going to start the medication if only there is a strong indication with close follow-up. If there are no any precautions like this, so we are going to initiate the treatment safely. But in both situations, we need to get an ECG at baseline after 1 day, after 1 to 2 weeks of initiating the medication or increasing the dose. If at any time there's increase in the corrected QT more than 500, so you need to consider to change to a different drug. If there is a strong indication, So keep on the medication but try to reduce the dose, and you may need to assess the drug serum level. If there is no problem with the QT interval, continue the treatment, inform the patient about warning symptom, control the dose if there is any problem with the renal or hepatic function, and be aware of any potential drug interactions. Let's now move to the device therapy, and we are focusing here of course on the ICD. In the 2021 ESC Guidelines for heart failure, the ICD had a Class 1 recommendation for secondary prevention to reduce the risk of sudden death and all-cause mortality in patients who recovered from a ventricular arrhythmia causing hemodynamic instability, expected to survive for more than 1 year with good functional status and in absence of reversible cause, unless the ventricular arrhythmia has occurred in the first 48 hours after MI, as this is considered a period of electrical instability. In these conditions, the ICD is indicated for secondary prevention. For primary prevention, it is also indicated to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure NYHA class 2 to 3, ischemic etiology unless the MI in the prior 40 days, as it is not indicated in this period, ejection fraction less than or equal 35%, despite 3 months or more of optimized medical therapy, provided that the patient is expected to survive longer than 1 year with good functional status. In this case it is class 1, as in ischemic LV dysfunction the risk of sudden cardiac death is higher. While in non-ischemic LV dysfunction it is indicated for the same purpose in patients with symptomatic heart failure, non-ischemic etiology, ejection fraction less than 35, despite 3 months or more of optimized medical therapy, expected to survive longer than 1 year, but here it is class 2A, as we are speaking here about non-ischemic LV dysfunction. And the big no in this guidelines that the ICD is not recommended in the first 40 days after MI, as at this time it does not improve prognosis or reduce mortality. In the 2022 ESC Guidelines for ventricular arrhythmia, ICD is also indicated for secondary prevention for patients resuscitated from documented VF or hemodynamically not tolerated VT in absence of reversible causes, and is also implanted for patients with a good quality survival for more than 1 year, the same as in the 2021 guidelines, and is also indicated as class 2A in patients with LV assist device with symptomatic sustained ventricular arrhythmias, as those patients deserve the right to have ICD if they are indicated. If the patient is having an indication for ICD but it is contraindicated, not available or refused by the patient, so amiodarone is a class 2B to be used. If the patient is having sustained monomorphic VT or sustained polymorphic VT or VF triggered by PVC with a similar morphology and the patient is indicated for ICD but also not available, contraindicated or refused, in this case catheter ablation may be used to reduce the risk of recurrence of ventricular arrhythmias. And the big no here is that it is not recommended to implant an ICD in patients with incessant ventricular arrhythmia until it is controlled, because of course I will not put a shock device in a patient who is having continuous ventricular arrhythmia. In this case I am torturing the patient by giving him multiple DC shocks throughout the day. I need to control the ventricular arrhythmia, treat the cause, and then arrange for ICD. A joint decision process should be adopted if you are dealing with a patient who is an ICD candidate, including communication of all the relevant information related to the device, ensuring a good understanding of the benefits and risk of the device, potential consequences of different therapeutic options like other options apart from ICD, the need for later ICD generator replacements. The patient should understand this and expecting this, and discussing the end-of-life care. This of course enables the patient to participate in decision making whether he's accepting ICD or refusing it. As we know that CRT also reduces mortality in heart failure, and so it adds to the mortality benefit when added to ICD if the patient is indicated for CRT. So in any patient indicated for ICD, we should evaluate whether he can benefit from CRT or not, because in this case I will put a CRT-D rather than CRT-P, and an ongoing randomized controlled trial called the RESET-CRT aims to determine the impact of CRTD on overall mortality and sudden cardiac death in heart failure patients with a CRT indication. A wearable cardioverter defibrillator is another alternative option that should be considered for adult patients with a secondary prevention indication who are temporarily not candidates for ICD implantation. For example, patients who had an extraction of an infected device and they are on antibiotic therapy at the time being. So of course I will not put a new device. I will use the wearable cardioverter defibrillator till the infection resolves and the patient can receive an implantable cardioverter defibrillator. It may be considered in the early phase after MI, like in the first 40 days, but in the VEST trial, which tested patients with MI and ejection fraction less than 35% to wearable cardioverter defibrillator or none under guideline-directed optimized medical therapy, after 90 days of follow-up there was no difference in the primary endpoint of arrhythmic death. The subcutaneous ICD is one of the innovations of ICD that has advantages and disadvantages. In the PRAETORIAN trial, patients with an ICD but no pacing indication were randomized to either SICD or transvenous ICD over a mean follow-up period of 4 years. Non-inferiority was shown for the primary endpoint of device-related complications and inappropriate shocks, and the rate of shocks was higher in the SICD group than in the ICD group. I'm speaking here about the inappropriate shocks, but the rate of device-related complication was higher in the transvenous group rather than the SICD. But in the secondary endpoints of death and appropriate shocks, there was no significant difference, and the trial had not been powered to show non-inferiority for the secondary endpoint. That's why SICD is still not a complete substitute for transvenous ICD. What are the advantages of SICD? Of course, it is suitable for patients with difficult venous access because it does not require venous access, only a subcutaneous position for the device and the leads, and it is suitable for patients who require ICD extraction due to infection. But what are the disadvantages? They cannot treat bradyarrhythmia, so if you put them, you can put them only for patients with no pacing indication for bradyarrhythmia. SICD cannot deliver anti-tachycardia pacing or CRT pacing. So in this case, it only depends on the shock therapy, and it cannot be used for patients who have an indication for CRTD. Also, it is less powerful than transvenous in SVT discrimination, and so the risk of inappropriate shocks is higher than transvenous ICD. So the recommendations in the guidelines that it can be used as an alternative to transvenous ICD in patients with an indication for ICD, but no need for pacing for bradycardia or CRT or ATB. That's why it is not a complete alternative, but in some specific situations it can be used. Optimization of ICD programming is indicated in any ICD recipient to avoid inappropriate therapies and reduce mortality. In single or dual chamber ICD patients without bradycardia pacing indication, it is recommended to minimize ventricular pacing to reduce battery consumption, and it is recommended to program the slowest tachycardia therapy zone limit more than or equal 188 beats per minute in primary prevention ICD patients. In patients with a structural heart disease, we should program at least 1 ATB therapy in all tachyarrhythmias zones. Programming of prolonged detection setting is indicated, like a duration criteria of at least 6 to 12 seconds or 30 cycle length intervals before the device diagnosed sustained VT necessitating therapy. It is recommended to program algorithms for discriminating SVT from VT with rates up to 230 beats per minute, and it is recommended to activate lead failure alerts in order to reduce the risk of inappropriate therapies and also reduce the risk of failure to deliver appropriate therapies. Remote monitoring is recommended to reduce the incidence of inappropriate shocks. Programming of burst ATB as a first attempt is recommended over ramp ATB because it is safer, as a ramp ATB may degenerate the VT into VF. For SICD, a dual detection zone configuration is recommended with activation of the discrimination algorithm in the lower conditional shock zone, and for routine programming, activation of more than one tachycardia detection zone should be considered. One of the lines to reduce inappropriate therapy is to have concomitant therapy for other conditions. For example, patient having recurrent SVT should be scheduled for catheter ablation to reduce inappropriate therapies for SVT, and patient with paroxysmal atrial fibrillation should have pharmacological therapy or catheter ablation according to his clinical situation to reduce inappropriate ICD therapies for AF. And beta blockers should be titrated to the maximal tolerated dose in heart failure patient with preference to carvedilol over metoprolol in order to reduce the rate of inappropriate therapies. To reduce the ICD complications, single chamber ICD is recommended over dual chamber in primary prevention patients in order to reduce the risk of complication during the procedure and reduce the procedure time if the patient does not have an indication for atrial pacing or AV sequential pacing, and the use of single coil leads over dual coil is recommended due to lower rate of complication, especially if the patient needed in later on lead removal, because the SVC coil may increase the risk of fibrous adhesion within the SVC, and there is no difference in the shock efficacy between single coil and dual coil leads. We need to pay attention to the psychosocial element of the ICD, because we need to assess the psychological status of every ICD recipient and treat the stress in any ICD patient, as the stress here is mainly caused by the concern of potentially receiving ICD shocks rather than by having experienced already an ICD shock. And so a communication between the patient and physician is recommended to address these concerns and discuss the quality of life issues before ICD implantation in order that the patient is expecting the consequences of ICD, and if needed you need to refer your patient to a psychiatrist. And the end-of-life issues should be discussed with the patient and the family about the ICD deactivation options in case of significant health status deterioration, and this should be discussed before implantation. And we are not speaking here about deactivation of antibradycardia therapy, as it is prohibited by law in some countries. We are speaking about deactivation of the cardioverter defibrillator therapy. And the last line of treatment that we are going to speak in brief is the catheter ablation. The fact that we are dealing with the ICD do not prevent ventricular arrhythmia, and many of these patients will experience symptomatic VT or VF recurrence resulting in syncope or ICD shocks, so requiring additional treatment like pharmacotherapy or catheter ablation. The advantages of catheter ablation that is successful in treatment of bundle branch reentrant VT, and so it is considered as a first-line therapy in this diagnosis, effective in controlling incessant VTs or electrical storm, and effective in reducing VT burden in ICD patients, and so reducing appropriate therapies. In patients with coronary artery disease, 3 randomized controlled trials reported that catheter ablation compared to conventional treatment decreases the likelihood of subsequent ICD shocks, and so it prevents recurrent VT episodes. And in case of polymorphic VT or VF initiated by similar PVC, where the triggering PVC often related to Purkinje network, it should be targeted for catheter ablation, as here the success rate is high, as in case of early repolarization syndrome and idiopathic VF. In patients with ischemic LV systolic dysfunctions, the scars are mainly subendocardial or transamural scars, and so the mapping here is usually endocardial mapping, while in non-ischemic cardiomyopathy, they are intramural or subepicardial scars, so here we depend mainly on the epicardial mapping. And when we plan for VT ablation, it is important to collect all available information about the arrhythmogenic substrate, like the cardiac MRI to assess the extent of scar by detection of late gadolinium enhancement, and the ECG during VT, and the PVC morphology to determine the exit site of VT. And the critical part of the reentrant VT circuit, referred to as the protected VT isthmus, is the primary target for ablation. And the ablation strategy, of course, gradually evolved over the years with more extended ablation of the arrhythmogenic substrate and higher success rate in the latest years. And we should not forget that idiopathic VTs have a benign prognosis, and so ICD implantation is generally not recommended. The target ablation site here is usually in idiopathic VT, the focal origin, which is the earliest activation site during VT, like RVOT or LVOT or papillary muscle in some cases, and in fascicular VT, it is the abnormal Purkinje tissue showing diastolic activity during VT, as here catheter ablation is the first line and ICD is generally not indicated. We are going, of course, to discuss the catheter ablation in detail in each specific heart disease with the role of ablation. So we have reached the end of our video today, and our take-home message that the risk assessment of sudden cardiac death and determining the etiology can decide the most appropriate line or lines of treatment for ventricular arrhythmia, like antiarrhythmic drugs plus minus ICD or plus minus catheter ablation. That's why meticulous assessment of your patient is essential to determine the appropriate lines of treatment. Thank you very much for watching this video, and next week we are starting the discussion of management of ventricular arrhythmias in specific heart diseases.